Welcome. I am Dr. Jason Schmidt from the Vance Thompson Vision location in Sioux Falls, South Dakota, and Alexandria, Minnesota. And welcome to the Dry Eye Dialogue, your one-stop shop for all things dry eye related. I've got two of my esteemed colleagues here, Dr. Nick Risperud out of Fargo and Dr. Lorraine Zimprick out of our Sioux Falls office. So welcome, guys. And Ray, do you have any burning questions you want to ask Nick that you haven't asked so far?
Take it easy on me.
Take it easy. I don't know. Um, how do you, so yeah, I mean, I don't do as many dry eye evals, as Jason here. But what is your approach to patients? You've maybe tried, a vast majority of things for patients and nothing seems to work, right? So the patient in the room, I have had it, but not as many. I don't see as many patients like this, but you're rattling off, okay, we could try cyclosporine, and they say, nope, I've already tried it, that didn't work, and nope, I've done this and that doesn't work. And so you've done a lot of things, and you've went down and maybe in-office procedures or whatever it may be. But how do you approach these patients that are just very challenging?
Let me get this straight. Let me get this
Get them
straight.
in a good
Yeah.
spot?
I said, take it easy on me. And then your question is,
This
how
actually
do
is
I
probably
handle
a
the
better
most
question for
difficult,
Jason.
driest patient? A good question.
Well, this is
I've done-
something though that
no, it's
I'm
tough.
gonna be learning from. I'm gonna be learning from you guys. So
I've done this once before. Yes, I'd say where it gets tough is like when the patient's been to multiple doctors. Well, and because they're frustrated. And so they have their primary optometrist. They've maybe been referred to a specialist, another, at my door. What have you tried? And I've got a list of stuff. And what are you doing now? Well, they're doing preservative-free tears, Restasis, cyclosporin. They have the heat mask. They're not doing it too much. They should do it more, but they forget. And you start adding these therapies or maybe taking some away, and you can really just get lost. What has the patient tried? What have they not tried? So I've done this before where I've said, you know what? Everything you have at home, stop. Stop doing everything. I've stopped every single treatment. Okay, you have a preservative-free tear at home, you can use that. But stop everything you're doing and come back in like 2 weeks. And then we just start adding things back on one by one. A lot of patients come to our clinics. They're frustrated because they've been dealing with dry eye forever and they haven't gotten an answer. And, I'd say most of the time I'm throwing the kitchen sink at it. Like I'm, starting a low dose steroid, maybe doing some punctal plugs, and then treating the lids. And I'm doing a lot. But for like the most difficult of the complicated of dry eyes, where maybe I'm getting a lot more complaints than I'm seeing signs, and they tried most things, sometimes I'll just stop everything they're doing and then just add things back on one by one. So I know what's beneficial and I know what's not. We've got some awesome therapies, awesome prescription drugs. No drug works for everyone. And the last thing you want is a patient on a drug that's adding no benefit. And so I've done that once or twice where I've literally just stopped everything and then added my therapies on slowly one by one.
I have a very good approach to these patients. I say, I have a partner here who is phenomenal in that area of expertise, and I'm going to send you over to his space. Jason, what do you do? Or how do you handle those patients when I send them over?
I try to get back to the root cause. Typically there's two things that are causing this. And I think with our diagnostic tests, I think we can figure out what the root cause is. And then I just have a strong belief that if I address the root cause, I'm going to get the patient in a good place. And so I think you just have to make sure you're addressing the right thing. Now, I'm checking cornea sensitivity a lot sooner than I've ever done before. So these kind of resistant ones, it's like, what is going on here? Why is this cornea still stained like it does? And I think that's a big thing that we probably have missed, or at least I've missed up until now, is I'm checking cornea sensitivity. And when I'm finding that, hey, that cornea is not sensitive like it should be, I'm starting patients on oxyrvate a lot sooner, or I'm using amniotic membranes a lot sooner. And I think those two things are just super important things to like use in the clinic when you've got these cases that are just not making sense. So check cornea sensitivity sooner.
I would agree with that. I've used oxybate quite a bit up here in Fargo to treat, stage 1 neurotrophic. It does get tricky sometimes with insurance to get those medications approved. But if you fight hard enough, they usually listen. So keep fighting the good fight on those. But I agree with you, Jason. Use a cotton swab and just test the cornea sensitivity quick because you usually find something. You may be surprised.
And sometimes, there's obviously patients that are coming in that have dry symptoms, but their eyes are watery. That it's always the confusing. Well, how can my eyes be dry and they're watering all the time? Well, it's because the water gland is working. The meibomian, the oil glands aren't working. The oil is what coats your eye to keep the tears in your eye. And if you don't have the oil, your tears are evaporating faster than they should, and your eyes water. And so those patients are going to have more symptoms, like you said, in the car, heaters, fans, air conditioners running, outside, windy day, whatever the case might be. It could also be a surgical thing. And so that's another thing to keep in mind. Is their tear duct closed? Is their tear duct not in the right position? It's pointing outward. Are their lids loose? Are they on a CPAP machine? They've got floppy eyelid syndrome going on. It could be a surgical thing that needs to be addressed too. So you've got these cases that are real challenging and you're like, I don't know what else to be doing. Well, maybe just kind of step back and think a little bit. Is the cornea working, or is this maybe a surgical case that I got to think about?
I agree, Jason. I think with watery eyes, physicians are pretty quick to diagnose just dry eye. Your eyes are dry, so they're watering. Um, yes, that does happen quite a bit, but I've sent a handful of patients to you guys over in Alexandria, Dr. Wristvet, because their lower eyelids are falling off their face. And that's, well, yeah, the tears aren't going to stay there. They're not going to stay on the surface because there's nothing there to hold them. So I feel like I've referred a handful of patients for a lateral tarsal strip just to tighten everything up. For these patients, I'll say, you can be driving a Porsche, but if the windshield's cracked, what good does it do? You can have a healthy eye, but if your cornea is dry and your lid, your wipers, aren't doing their job, nothing's going to help us. Drops aren't going to help. And, these LipiFlow and eye lock, they're not going to work because your eyelid is just sitting way down here.
That tension when they blink, that if the lid doesn't have any tautness when you're blinking, nothing's going to come out of that. We got to get some tautness back in. If that lid is super loose, it's just going to be like, a wet fish when you blink. So
yeah, and I have every once in a while I'll do a dilation irrigation, and I'm surprised every single time. It feels like where I'll try to shoot saline down the punctum, and I've emptied the whole thing, and I haven't passed any through to the throat. So I've also referred a handful of patients. Last time I did, a patient came back and said, "Thank you for listening. Thank you for doing something other than starting me on a new eye drop." Because after my DCR surgery in town here, it's the first time in 3 years my eyes have stopped watering. So I would say, yeah, watery eyes, epiphoria, probably dry eye a lot of the time. Not always.
not always. Well,
Jason, one quick question.
yeah.
One quick question on that. When you, or either of you, I guess, when you do Jones testing and you find that it is stenosed, do you guys start them on any treatment initially, or do you just send them right away to ear, nose, and throat?
So I kind of base that on how long it's been happening.
Sure.
And it's like both sides, because that's weird that it would be both sides, right?
Yeah.
So maybe it's like just some recent onset inflammation. So I try to start patients on a nasal steroid spray first.
Yeah.
Just because there's something blocking down in there, and a drop can't maybe get to where I need to go. So I start them on a nasal spray, a steroid nasal spray like Nasacort or Nasonex or something like that, twice a day for like 3 weeks and reassess. And I bet probably a third of those open up. But when you hear from the history that this is more long term, this has been going on for several years, you also ask if they had any prior like nasal surgeries or sinus surgeries and things like that. Because if they have, then they probably need a DCR.
Yeah. Very good.